Hi, my name is Ali and I'm an F2 working in Portsmouth. Today I'm going to talk to you guys about upper GI bleeds. This is a massive topic and we will go through it step by step and logically, but it's a very important topic to know for now, for exams, and for the rest of your career. So the main focus of this teaching is going to be on the two main causes of upper GI bleeds, or what I think is the most important: peptic ulcer disease and variceal bleeds. We will briefly touch on some other causes. Now, this is a detailed review. Extra information is included for those more keen. Um, I'm not saying you have to learn everything written down here. In fact, it's by no means a necessity at all, but it will help. So, when you're revising and doing oral examinations, it's always important to use classifications. For example, classifying investigations such as bedside, bloods, imaging, invasive. This will help you not only remember things for an exam, remember things on the ward, but you'll also sound more professional in an exam as well. So on the last two slides here, I've written like a guideline or a frame on how you can phrase your ABCDE. It's what I like to use myself. So instead of saying I would check respirate or whatever, you can say parameters I would look for in breathing would be respirate or saturations. Some examiners like it, some are indifferent to it. It's what I use. I'm not going to talk through them because it's just pointless, but find what works for you, memorize it well, and stick to it. Moving on from peptic ulcer disease to the real crux of upper GI bleed is esophageal varices. So varices and varicosities basically mean a dilation or dilatation of veins. So esophageal varices, the definition is dilations of the portosystemic venous anastomoses, specifically in the esophagus. Sounds complicated, but we'll talk through it and make it easy so you'll never forget it. So the portosystemic venous anastomoses are abnormal connections between the portal venous system, so the liver's venous system, and the systemic venous circulation. And we'll explain that a bit more in the next slide. So, normally blood flows from the GI tract into the portal vein, which takes it to the liver. The liver then does its metabolic function on the blood before this blood is then returned to the systemic circulation via the hepatic vein. So, if there's high pressure in the portal system, so portal hypertension, the blood flow through the portal vein into the liver is reduced and slowed. As such, a different outlet is required. Because of this, abnormal anastomoses develop between the portal and systemic circulation, and then more blood is directed and diverted through this side channel instead of going through the liver. As more blood is diverted through this channel, these vessels dilate, and this increases the pressure on their walls. As the pressure increases, they're more likely to rupture. If you want to be more scientific, you can say bleeds occur when tension on the variceal wall exceeds its elastic limit, and this is i.e. portal venous pressure. Although we mostly hear about esophageal varices, other portosystemic anastomoses do exist. One you might be familiar with in your examination are the umbilical ones. So this anastomosis is what results in caput medusae being apparent on the abdomen. A few others I've listed here for interest. You don't need to know them for finals. You do need to know them for MRCS exams. So, causes for portal hypertension. When you're asked about varices, you just think cirrhosis, but more scientifically correct is that it's caused by portal hypertension. The causes for portal hypertension are classified as prehepatic, hepatic, and posthepatic. So prehepatic is portal vein obstruction. This can be via thrombosis or compression from an external source, i.e. massive splenomegaly. The most important hepatic cause is cirrhosis. This can be alcoholic, non-alcoholic, fatty liver disease, or viral hepatitis, for example. Post-hepatic causes. So what's going to stop the blood going out from the liver? So right heart failure, constrictive pericarditis, or Budd-Chiari syndrome, which is obstruction of the hepatic vein. This lovely diagram of the portal venous system, we can see the portal vein is formed from the anastomosis of the splenic vein and the superior mesenteric, which has sadly been cut off. The blood then flows into the liver, where the liver does its magic, and then into the hepatic veins, into the inferior vena cava, and into the right atrium. The reason this diagram is included is just to give you a better idea of the flow of the portal venous system, and then you can appreciate the difference between the portal vein, which is pre-hepatic, as you can see at the bottom, and the hepatic veins, which are post-hepatic up there. So Budd-Chiari syndrome affects the hepatic veins at the top, and portal vein thrombosis is inferiorly. First presentation of esophageal varices is often from a GI bleed. Not always a major hemorrhage, but sometimes a small amount of hematemesis, some hematochezia, which is a fresh PR bleed, or melena. When you're taking the history, you want to focus on alcoholic history and also IV drug abuse, just to ensure bloodborne viruses are being excluded. Examination, you're just looking for signs of liver disease, so ascites, splenomegaly, caput medusae, and the PR exam may reveal fresh blood or melena. Investigations. We start with the classification, bedside, history, and exam. Moving on to bloods, you want to look at the hemoglobin and the platelets. The platelets are the most acute and most sensitive marker associated with portal hypertension and larger varices. You want to look for any evidence of a deranged LFTs or the UGI specifically if the urea is raised. Now, if you ever discuss with a gastroenterologist saying you have a patient with a suspected upper GI bleed, one of the first questions they're going to ask you is what is the urea? So in terms of imaging, you can do a chest and abdo x-ray to exclude other causes of an acute abdomen, for example, a perforated peptic ulcer, and more or less commonly a CT or MR angiography. But the gold standard and investigation that everyone will require is an OGD. This is both diagnostic to visualize any bleeding and also can be therapeutic with certain interventions, which we'll learn about soon. So several scoring systems exist for determining severity in an upper GI bleed. I'm only going to talk about the Rockall score because it's an examiner's favorite. So it's used to determine severity of an upper GI bleed, and there's two scores. One is the pre and one is the post endoscopy score. So here we can see the pre endoscopy score. The post endoscopy score is the same as this, but includes the diagnosis and any evidence of recent hemorrhage. It's good to know this for exams, but it's definitely not necessary. So this is a treatment summary slide for the management of esophageal varices in an elective setting. So starting with conservative, you'd reduce alcohol intake. This doesn't treat varices, but prevents worsening of alcoholic cirrhosis. Medical management would be treating underlying cause, first of all, for example, hepatitis B. If it's a viral hepatitis driving the cirrhosis, then you can use non-selective beta blockers, for example, propranolol. These reduce portal pressure, and they can also be used as secondary prophylaxis for bleeding. So, for example, if patients had a variceal bleed before it's been resolved, you can start them propranolol afterwards. PPI is not routinely recommended unless they're undergoing intervention, for example, ligation or banding, although it's often started by a lot of doctors. And finally, vasopressors. These prevent the recurrence of bleed. An example would include terlipressin. Interventional management can be an OGD. From there, you can do ligation or banding, and also a TIPS. TIPS is something you hear quite a lot about. What it stands for is transjugular intrahepatic portosystemic shunt. It's called transjugular as that's the approach the radiologist uses through the jugular vein. It's a shunt that connects the hepatic and portal veins together. And basically what this does, it bypasses the cirrhosed high portal pressure liver, and it just gets the vein directly into the systemic circulation without the need for diversion through anastomosis. In an emergency, So you'd say I'd resuscitate the patient based on ALS ABCDE guidelines. A, I'd ensure the airway is clear, specifically the use of suction, as they may aspirate because of the amount of blood being vomited. In terms of breathing, just ensure oxygenation is adequate. The most important thing here is circulation. So IV access bloods, including coag and a group and save. You treat any coagulopathy if present, and most importantly, a massive transfusion protocol may be required, and also then start them on transfusion or IV fluids. In terms of D&E, you just assess the GCS, which is the most important, and then just exclude everything else. Treatment of variceal bleed in an emergency setting. I apologize, the slide is quite busy, but we will go through it step by step. So first thing, IV terlipressin. This is a splanchnic vasoconstrictor. What this does is reduce blood flow to the portal vein, which means there's less blood for the varices and thus less bleeding. IV proton pump inhibitors are given, and IV antibiotics are started. These are started as a prophylaxis to prevent spontaneous bacterial peritonitis, which is a risk factor from a variceal bleed. So medical management is more as a precaution before interventional procedures are carried out. These begin with an OGD, and when the bleeding varices is identified, you can then either do ligation via banding or sclerotherapy as a second line. We talked about tips already. Now, you may have heard about zinc stack and Blakemore tubes and Minnesota tubes. So what these are methods of balloon tamponade or self-expanding metal stents. They're inserted via OGD and they're used only in massive hemorrhages. They're inserted to the words the lower esophageal sphincter where they're expanded, compressing blood flow and then reducing the amount of bleed from the varices. After this is done, the OGD will then, and the endoscopist will then either do variceal band ligation or sclerotherapy. So the surgical management I've included for interest's sake. You can look it up if you want to, but we won't go too much into it. Okay, so other causes of upper GI bleed. You can classify these into esophageal tears, which can either be partial thickness, so a Mallory-Weiss tear, or full thickness, which is Boerhaave syndrome. These occur from repeated vomiting. For example, the classic question will be a young person after a night out is quite hungover, and then they notice some hematemesis, and it's because they've been throwing up all night. Mallory-Weiss are normally managed conservatively unless it's profuse bleeding, and Boerhaave's are typically require an operation. You can also say inflammation, esophagitis, most likely associated with GORD, malignancy such as gastric cancer, and vascular. I am not going to try and pronounce that lesion, but it's not very common, but it's just important to know about. So it's just a tortuous arteriole in the gastric submucosa, which is prone to bleeding. Last line. So ABCD is key. Learn your ABCD techniques word for word so you don't miss things, but don't make it sound too long as to bore the examiners and your vivas. Remember, all management begins with resuscitation, and then you go into your steps. Classify everything, and you'll be grand. So I hope this wasn't too long or boring for you. If you do have any questions at all, please feel free to email me, and I'll get back to you as soon as I can.